Good afternoon, everybody. I am visited today by one of the most interesting men that I think I know, Dr. Burak Gezen. And he is a medical doctor. He is also a world champion chess boxer. And he is on cutting edge, probably, I would say, a health expert with biological age identity. Did I get that right?
Sure. I'm flattered, but yes.
Well, there's a lot more to you as well. I think you're a purple belt, about to be a brown belt.
In jiu-jitsu?
In jiu-jitsu, correct.
Debatable when I get my brown belt, but we'll see.
Depending on your instructor to give you that. But I don't think I know nearly, I don't even know how to put this, but most medical doctors are not nearly as interesting as you. Most of them go day to day, they have one specialty. That's all they do, that's all they focus on. They're great at it, but most of them are overweight, out of shape, they work too much, they have too much stress, they don't eat properly. They're the ones that I train, and I have to keep accountability on them because they know what to do, right? I put that in quotes, but they don't do it. So how do you become world champion chess boxer? And explain that too, because I think a lot of people don't know what that is.
I guess I'm a little bit of a, what's the word I'm looking for? I go against the grain. So when I was doing my medical,
You don't say.
when I was doing my medical residency training, I kind of saw that we were treating sick people who weren't really going to get better with all these crazy medical interventions, and they were just cycling between home, nursing home, hospital. And I didn't really feel like I was helping anybody. I guess everybody was making money. And patients sort of had these unrealistic expectations of what their goal was going to be. And I don't know, I just got very disillusioned by the whole experience. So at that time, sort of the way to go against the grain was to go into hospice, was to say, hey, we don't have to keep you on life support. We don't have to keep doing all this nonsense that we're doing. There is a way. I mean, that's where I was in at the time. I was, doing inpatient medicine, taking care of sick people in the hospital. And when I was doing my hospice training, I saw this paper that completely changed the way I viewed everything. It's a simple paper. It wasn't like a randomized controlled trial. It wasn't even an experimental thing.
Where'd you find the paper? Where'd you get that from?
It was part of my hospice training. It was in the journal of British Medical Journal, Hospice Journal.
Okay.
It was like written in the 1970s. Basically, all it was a group of experienced clinicians who described trajectories of terminal illness.
Okay.
So basically what they described was that people over time, when they have certain terminal processes, whether it's organ failure or dementia or malignancy, will go along sort of a stereotypical pattern of what their functional status is. And the reason it sort of had this huge impact on me was the first time I saw a function over time graph, where I saw, this is time and this is function and this is how the person's function over time is going to be. And I never really thought about that before. So then I started thinking in my head, extrapolating, well, what happens before we get to the terminal phase? Like, we're born, I went all the way back to the beginning, we're born with, very limited function. We can breathe, we can, suckle on a nipple for milk, and that's about it. We can poop.
Right.
And then as we, age to about the age of 12, we're gaining all these tremendous functions. You go from that to, climbing and doing math.
So what was the point? What was the decline?
So my understanding was, so if I want to age well, I need to be as the highest level of functional status as I can be. And as I age, sure, I'm going to lose some functions, but I can gain others. And the hypothesis I had in my head was that if I keep pushing myself and keep looking for new experiences and gain new abilities, my functional status is going to go up essentially until I get to the very end of my life.
Sure.
Yeah. Maybe I'll lose things like explosive power.
Not as much.
Not as much if I work
and
it.
A lot of times other things run parallel.
Exactly.
Cognitive effect is going to be with exercise.
Exactly.
And all that. Okay.
So I might lose some things, but I can gain some other things.
Sure.
Like I can keep my isometric strength. I can gain wisdom and knowledge and nutritional health. That's a function to understand how to go into a grocery store and come out with the right stuff.
Right.
Everything's a function. You can get really creative with what is functional.
So because
status.
of that, you can be healthier at 50 than sometimes you are at 20.
Yeah, for sure.
Which is why in my clients, some of my healthiest and fittest clients are in their 50s and not their 20s.
Yeah.
I can name a dozen that are incredibly healthy.
This happened when I was about 35. I'm definitely healthier now than I was when I was 35. When I was 35, I got Achilles tendonitis just walking around the hospital. And that was one of the moments where I was like, you know what?
Were you fat?
At that point I was 180, 85 pounds,
so
and
no,
I was
you're-
probably about 30%, 35% body fat, I'm guessing.
Oh, you're 30% body fat.
Yeah, I was a
Not
bit,
your BMI.
no, I definitely didn't have a lot of muscle. I
Wow.
couldn't fit my shirts, like my arms were skinny, and I was actually quite rotund. I'm sure I had visceral fat, I had metabolic syndrome, I had all the things. And I saw my functional status. At that point I was like, okay, I can't have the functional status. I can't walk a full day without getting Achilles tendonitis.
Wow.
So that's
Okay.
like,
Now, what's your body fat now?
I think probably around 12.
Okay.
I've been sub 10 before. When I'm really training for competition, which I guess I will
sub
be.
10 is insane. I mean,
What?
that's elite status.
Yeah.
You're in bodybuilding competition at that point.
Yeah, that's when that happens when I'm like right at the cutoff. If I weigh 168 and the cutoff is 168, and I've got 6 weeks before, and I'm like really pushing myself because I want to make weight, then I'll get to sub 10. But usually I walk
Okay.
around 12.
Now, explain back to chess boxing. Explain exactly what that is. You literally play chess,
You
and
play
then you
chess.
box, and then you chess and box, right?
Yeah, 60 Minutes actually just did a segment on it, but it's just like it sounds. So you've got a certain amount of time on the clock. For a championship round, it's 6 minutes on the clock. You and your opponent play 3 minutes on the board. Then the board is frozen. Wherever the clocks are is frozen. Maybe I used a minute, maybe you used 2 minutes. And then we put our gloves on. We box just like regular boxing.
So you don't have to have your gloves while you're moving the chess piece.
That would be a little bit challenging.
Okay, but that's
yeah,
nice.
you do
So-
have to take your gloves off and
Okay.
on between rounds. So unlike traditional boxing where you
And
keep
then
your
they ring a
gloves-
bell.
and
you
they
go
ring a
again.
bell, and then you
Okay.
box, and then you go after your boxing round, assuming nobody got knocked out. Then you go back to the chess game that you were playing before with the same time controls, and you play another round of chess, and you go back between your chess and boxing.
And if you get knocked out, game's over.
If you get knocked out, game's over.
Or
if you get checkmated, game's over. If you've got 4 knockdowns, game over. And
Okay.
an illegal chess move is a knockdown. So if
Okay.
you get hit and you get knocked down, but
Interesting.
you get back up, that's a knockdown. Which has happened before. People after
Sure.
the boxing round, they come back to the chessboard and they'll make an illegal move. They'll move the other opponent's piece.
Oh,
they're
wow.
like they're white, and then they move the black piece.
Okay.
And then like, no, that's an illegal move. That's a knockdown. If you
Gotcha.
get 4 knockdowns total or 3 knockdowns in one round, it's
And you have
also
the
over.
judges all watching these.
There's a chess judge for the chess portion, and there's a boxing referee for the boxing
Okay.
portion.
And you won the world championship
I did.
recently.
I did.
Okay. And that was in.
That was in Serbia.
Oh, gotcha. Okay.
Yeah, that was in Serbia.
Okay. So, like I said, most interesting man that I know. Chess boxer, almost a brown belt in jiu-jitsu, medical doctor, starting up a new practice, which a lot of doctors don't even do that. They won't branch out from hospital system. So you
Yeah.
take a leap of faith. Now, were you at, was it Runken Pratt Nursing Home?
So my brother does the Runken Pratt.
That's right.
I do Heritage Green Assisted
Okay.
Living. I did do a stint for a couple years as medical director of Lynchburg Health and Rehab, the skilled nursing facility, Appomattox Health and Rehab, during COVID.
Okay.
I've been a hospitalist for about 10 years now, so
Okay.
I'm leaving hospitalist.
Gotcha.
I could retire and just do chess boxing and jiu-jitsu and rock climbing and all that other stuff.
But
I'm
that's
a
why
little
you're
too
here
young.
today.
A little too young to retire.
That's why you're on the podcast now, because you don't retire. You don't do things the easy way. So.
Yeah, I feel like I'm gonna have too much fun combining my athletic sort of passion with medicine. So that's why I'm doing this clinic here.
So I want to get into one of the questions starting out. So if we were to look at pure longevity, why would America be healthier if people saw their trainer twice a week and their doctor twice a year instead of the opposite?
Exercise and athleticism is number 1, 2, and 3 on a, you would give me a list of the top 5 or top 10 most important things for longevity. What's the most important thing? I'm going to give exercise like 1, 2, and 3.
Okay.
You can actually exercise.
Not many doctors that would say that, by the way.
I feel like anybody in the longevity field would say that. But by the way, the longevity field, I didn't even know this was a thing. When I was starting this, I was thinking athletics and medicine, and I
Sure.
just learned about this field of longevity medicine that people have been doing for about a decade now. There's a book that Peter Attia wrote called
Attia,
Outlive.
It's a good book.
He says it multiple times in the book, which I agree with basically everything he says in that book. It's rare for me to read a book, like a medical book like that, and to agree with so many things that the person is saying. I mean, I agree with a lot of things, but...
Well, he's very evidence driven. So he likes to find the evidence on, whether he agrees with it or not, he will present the evidence.
Yeah. If you're just seeing your doctor a couple times a year, your doctor's, your doctor's going to tell you, what do all doctors tell you? You need to lose weight, you need to exercise, but a lot of them don't know how to do it themselves.
You'd be surprised. I have a lot of clients that their doctors never told them to lose weight. They simply suggest a pill or some other way or means. And if they do say lose weight, it's through Ozempic or the GLP,
wild.
Whatever it may be.
That's wild.
Or even Adderall. You'd be surprised that people taking Adderall to lose weight and the doctors prescribe it.
That's wild, man.
And that's for me, I know, is why the people don't have faith in a lot of the doctors, a lot of the allopathic doctors.
Is it because, I don't know, maybe you should be asking me this question, is it because the doctors don't think that if they tell people that they should exercise, that people are going to listen? Because that's what I hear from the doctor's side, is that we can tell people to exercise, but they're not going to do it.
Or the doctor themselves are fat and out of shape, lazy, whatever it may be, with not necessarily lazy, because they're obviously doctors, they're very smart, they pushed hard through medical school and residency, but maybe they don't know about it. Maybe they're ignorant to what exercise can do, and that's all they learn.
Yeah, I mean, Ozempic has a place, it has a role, but I mean...
Right, if you're never going to lose the weight, and you have more heart issues or whatever, diabetes or something like that that's coming on, then taking it's better than not.
It should be a temporary measure. And in studies that have done, for example, if somebody has low testosterone, and you replete their testosterone, but they don't do any exercise, you don't help them. You don't decrease their risk of having any sort of negative health outcome. You can't just do the medicine and forget about the exercise.
Right.
So, I mean, and like Ozempic, I mean, I'll prescribe Ozempic, but it has to be combined with some sort of medically guided exercise regimen, and it should be really temporary. Ozempic, people love Ozempic, I guess, but it does have some side effects.
Right.
And
muscle wasting, it was one, right? Bone density is number two. Thyroid cancer on the uprise, which we're just starting to find out in the last few months, right?
You can also get some rip-roaring infections in your places where you don't want to be getting rip-roaring infections.
I'm not following. What places? Males and females?
Males and females. Yeah,
Okay.
You can get nasty UTIs, but you can also get like Fournier's gangrene, which is you don't want to even know what it is, but it's terrible.
That sounds pretty nasty.
We're going to get into a conversation about the pharmaceutical industry now. When pharmaceutical industries study medications, for example, Ozempic or any medication, they are going to focus the study on the people that they feel like are going to have the most benefit and not have complications. So if I'm studying Ozempic for weight loss and diabetes, I'm working for the pharmaceutical company, I'll say, let's study people between the ages of 25 and 55 who only have diabetes, who are overweight, who do not have underlying heart failure, who do not have liver failure, who do not have renal failure. All right, let's just study it in that population, because that's where I'm going to be able to show most likely that there's a benefit. And then once I show a benefit in one patient population, that's all I need is the drug company, because now that's all we have and there's the benefit. Now that's the best available evidence. So if you're 65 years old or 75 years old and have all these comorbidities and you're coming in and we're saying, well, what's the best thing to do? The best available evidence we have is in this study, which, it might not be you, but we don't have anything about you. All we have is this, and it helps this group, so maybe it'll help you as well. So then all of a sudden it starts getting prescribed to all these different groups of people that it actually wasn't studied in. This is a big pet peeve of mine in geriatrics.
How long does it take for those studies to be non-biased to the one group?
It takes about, in my sort of experience, understanding, it takes about 15 years.
Okay.
So like once Ozempic has just come out now, and then in about 10 to 15 years, we'll find out that these are the populations that we shouldn't be prescribing it to.
Sure.
And even then,
one size fits all. It's dependent.
Even then, like there's going to be so much momentum already that it's just going to be, there are going to be a few people who are trying to not do that, and it becomes a mess.
Do you think there's ever going to be some scientific breakthrough to where it is a quick fix that has no side effects? Because I feel like, as Americans especially, it's always jumping on the quick fixes constantly, and then we always find out 3 years later the side effects. And you know what I'm going to ask next, because I mentioned this earlier today. The COVID. We're going to get into COVID too.
Yeah.
But I feel like initially we always jump on these things, quick fixes or things that aren't researched properly, and I mentioned that too, with the polio vaccine. First 10,000 people either died or had serious issues until we got it right. And we just jump on stuff consistently to help us, whether it be through weight loss or muscle development or just a simple vaccine, and we don't do the research long enough. Do you think there's ever going to be something that we are going to find, I guess, two-part question. One, are we ever going to not jump into it too quickly before the research is done properly? And two, is there going to be something that we can have to help fix these issues?
Okay, so Vinay Prasad, he wrote this book called Ending Medical Reversal. He's up in the government now, worked for a period of time with the Trump administration. But he asked precisely this question. So it's happened in medicine many times that we were doing something a certain way for a number of years, and then some study comes out, and then it changes our practice. And then after we do that for a while, we have to go back to the way we were doing it before because we got it wrong, basically. He calls that a medical reversal.
Okay.
Which is basically...
It's like the egg dilemma.
What's the
Eggs are good, eggs are bad. Eggs are good, eggs are bad.
Yeah, and so he talks about this actually in his book, like what it would take for that not to happen.
Sure.
And what it would take is a less capitalism-based system, more public funding for research, and a unified research pool. So like all of us, everything going into some database where we're all basically test subjects. And I don't necessarily see that happening in capitalist, pharmaceutical industry-driven America. And the second part to that is, are we ever going to stop jumping on stuff? This is going to get into a little bit of a psychology. So one of the hardest things to do in medicine is nothing. Patients don't like it.
What do you mean by that?
So for example, if I do a chest x-ray of you and I see that you have a mass, the hardest thing to do is to do nothing about the mass.
Okay.
The doctor isn't going to want to do nothing. The patient's not going to want to do nothing. Like everybody has to do something.
Okay.
It's hard to do nothing. This isn't just the doctor's fault. I'm going to go on a little tangent here.
Right.
So when I was training in residency, there was this guy who came in. I saw him at the point where he was getting his feeding tube moved from his, stomach to, moved from his nose into his stomach to directly into his stomach.
Okay.
This was a 35-year-old healthy guy, and the way he got here was because somebody found a mass that turned out to be nothing on X-ray. And I could get into the story of the complications of how this happened, but it ended up being like procedure, complication.
So he did the procedure, which he didn't need the procedure, and then that caused complications.
Exactly. So, the mass got biopsied.
Okay.
The biopsy had a complication. They tried to fix the complication with another surgery.
Sure.
That caused another complication, which required another surgery, which caused another complication, which caused another complication. And the sort of tragic comedy of the whole situation is when I was looking at everything that had been done, he wouldn't have been able to successfully sue anybody any step of the way. Because the first procedure to biopsy could easily be justified, and every procedure that he had subsequently, he signed the consent forms saying this is the procedure we're going to do and here are the risks. And everything that had happened to him was within the scope of the known risks of the procedure. All right?
Okay.
And then the flip side of that is, so one of those medical reversals, sorry, you talk to me, I get on tangents. Have you heard of PSA testing?
I have.
Okay.
Yeah.
When PSA testing first came out, we started testing everybody for PSA,
Right.
and we found all this prostate cancer, and we started taking out all these prostates. And then we found out that a lot of prostate cancer actually isn't a big deal. It's almost natural. It's, people are going to have low-grade prostate cancer.
I have heard this.
Yeah, so people will have low-grade prostate cancers. Those just kind of come and go. And we found out by taking out all these prostates, for every 10 prostates that we took out, we helped one person beat cancer. The other 9 people, even though they had cancer from what it looked like with an elevated PSA and on this slide it looked like cancer, it wouldn't have caused them any trouble. And for every 10 people that had the prostate surgery, like 4 or 5 of them had significant complications.
So how do you know which one you are?
We look at things like the trend of PSA and how high the PSA is. We've got other, so there's a time where once we started figuring out like, hey, we're hurting people by checking all these PSAs and taking out all these prostates, there was a flip switch. And so now the medical societies were saying, we don't recommend prostate screening for everybody. You need to have a discussion with your patient. We're not really sure what to do with the results. So there was this resident at that time, this was when I was training, who had a discussion with his patient like, we've got the PSA, we can do it, we can not do it, we're not really sure how to interpret the results, we're taking out a lot of prostates, we're hurting people. His patient decided, I don't want to do the PSA testing. That patient ended up getting prostate cancer that killed him. His family sued, and they won multiple millions of dollars.
Mm-hmm.
So comparing those two cases, you've got one case where somebody comes in with a mass that you shouldn't necessarily do anything about, but if you don't do something and it turns out to be bad,
Right.
you're going to get sued. If you do something and cause all these complications.
Well, ultimately, it's always the patient's, consensus, and they're
Right. Yeah. So but if I tell the patient, so then that gets into another thing. So I've got my two recommendations. I've got my medical recommendation, which protects me medical legally. If you have a mass, my medical recommendation is going to be biopsy it.
Biopsy.
Because
Or-
why, if I biopsy it and nothing's there, even if you have complications, I'm medical legally in the clear.
Sure.
If I
sure.
say don't biopsy it and it turns out to be something bad, you could sue me.
Well, there's a psychological effect
It's
too.
psychological.
I mean, people can't sleep at night if they know they have a mass. They
Exactly.
don't know what it is.
Exactly. So this is where it gets really complicated. How are we not going to jump on, for example, we'll go back to COVID. COVID's this new disease. We don't know how deadly it is. We know about SARS virus that had a 50% mortality. The first reports of COVID coming through nursing home facilities were wiping out like 30% of the nursing homes. We also, there's a lot of things we don't know about new viruses, like the HIV virus, for example. When you first get HIV, you get the flu. Then
Right.
it integrates in your DNA, and you find out 10 years later that you've got AIDS, right? We don't know if COVID's going to do anything like that or not.
Sure.
So if there's a vaccine that looks like it's got promise,
That's going to prevent.
then of
Yeah.
course we're going to jump on. It goes to the same psychology. To do nothing is
Right.
incredibly difficult.
Do you think there was some pharmaceutical push and lobbyists that did more? Do you think the patients came second with the COVID vaccine or other different vaccines?
That's hard to say. I can say from me personally, it wasn't. I mean, I never got any kickbacks for
They
prescribing
didn't push
COVID
that, or-
vaccines.
okay.
They didn't push it on me.
But I know hospitals did. If you said you died from COVID, there was a big. What would they say? The hospital got $40-something thousand per COVID case.
I don't know anything about that. I know for some patients, I would say on the death certificate that they died of COVID, and there were some patients that were trying to argue with me, saying that I was doing that for hospital reasons or
Right.
for some other financial reason, but
Right.
that never really affected me.
And I'm middle
Yeah.
ground because
Yeah.
I hear the people, and I train a lot of doctors, and another doctor said, he was complaining, we were talking about flu vaccines and all that, and he said, people think I make millions off the flu vaccine
Yeah.
giving it. He said, I make probably 40 cents.
Yeah.
He said, I do it because I think that's what's best for that person. And you have the people on both sides that are pushing their agenda, and you got to meet in the middle somewhere. Like, hey, yeah, there is some conspiracy, but there's also not quite as much as what you think.
Yeah.
So we're still finding things out, but I do know, and I mentioned this before, there's 6 new billionaires in that first year of the COVID vaccine. And you wonder, how it got passed so quickly, how, they're pushing it as hard as they could possibly push
Operation Warp
something.
Speed.
It really was
Yeah.
on something we had no idea about, messenger RNA and the way it interacted with the body and what it did. When everyone ended up getting the COVID anyway, the vaccine's supposed to prevent, and then they change it, they shift it a little bit, and then it's like,
I still think the COVID vaccine was beneficial. I think we probably, for what it's worth, I think there was a period of time where we were like doing the vaccines over and over and over, which I don't know if that was medically necessary
or
or not.
myocarditis, which I've had multiple people around me that have had it.
So the last time I looked into this, because I look into stuff too.
Sure.
The risk, and I saw it actually. The only time I saw really bad, somebody actually die from myocarditis, was from actually COVID, and it was a young 20-year-old. The risk of myocarditis from COVID is 10 times higher than the risk of myocarditis from the COVID vaccine.
What research was done from that? Like, where did that come from?
I don't remember. This was, the last time I researched was during COVID, actually.
So what you're saying is they could be on the same level of, like, getting COVID would be the same as getting the vaccine, kind of thing. If you're at risk, you're going to be at risk regardless of both.
I think so. That's my supposition, is that who knows, everything's risk-benefit. If you told me, I don't want to do any medication that has potential risk to it, then there's hardly anything I can do in
Can't take
medicine
medication.
at all. Can't really take any medication. Maybe you can take Gas-X, but that's about it. You can't take a baby aspirin.
Sure.
You can't take statin. You can't take Pepsid. You can't take omeprazole. Omeprazole actually has a ton of risk. It's one of my pet peeve medications.
So let me ask you this. All or nothing. Would you, if you had the option to have every medical doctor, every pharmaceutical company, anything you could have access to on an allopathic side of medicine, or and no exercise whatsoever, or
No exercise? Oh my goodness.
or have all exercise, all diet properly, exercising, things like that, but nothing medical. What would you choose?
And hands down, forget the medicine.
Really?
Yeah, no question.
And you're a medical doctor saying that?
Absolutely, there's no question.
That's big.
From a
That's a
public,
big statement.
it seems very.
I mean, I agree with you, but I'm a personal trainer.
I don't know. I feel like I would be interested for you to ask, pool the doctors that ask you the same question. I feel like they should all answer the question the same way. I would be surprised if they didn't. But yeah, I mean, hands down.
You think the government officials would say the same thing?
I think so.
Think so?
I mean, Kennedy? Yeah, of course Kennedy would say that.
Well, true. He might not have been, corrupted quite yet.
I don't know.
There's still time.
I feel like the doctors I talk to, they would all say that.
That's good to hear. Okay, because I agree completely.
To me, it's not even controversial. It's not really debatable. Yeah, there's no question. And you're saying no exercise. I mean, that's
no
horrible.
exercise. Yeah, right. Yeah. And there's so many studies that compare, even simply walking. 10,000 steps, 15,000 steps, more or less the grip strength you're talking about, doing, being able to do push-ups and, gripping hold and planking challenges and all of that. But so tell me, let's dive in a little bit because we don't have much time, but dive in a little bit about what you were creating with your practice. You're wanting to do basically biomarking your age, right? I
suppose so. That's kind of a thing that's very vogue now is biomarking your age. Before I learned about the field of longevity, I was an athlete and a hospitalist, working the night shift, whatever. So I wanted to build a clinic that combined medicine with athleticism. Now I've learned about longevity. It's a thing people have been doing for 10 years. Longevity and athleticism are inextricably linked. So I'm kind of doing the same thing. So I'm calling it longevity-based practice.
Okay.
But basically the plan is here that we're going to do a comprehensive cardiopulmonary metabolic functional medical assessment. Yeah, that sounds right. So we'll go step by step. For pulmonary.
Yeah, layman terms.
Yeah. So we're basically going to look at your lungs. We're going to look at your heart. We're going to look at how your metabolism is working. We're going to make sure you don't have any underlying medical conditions.
Through VO2 max testing.
Yeah. For the lungs, just the easiest, pulmonary function tests. So I've got PFTs here. People have heard pulmonary function tests. Just make sure that your lungs can,
I know what that is, yeah.
expand. Can you get air in, air out?
Gotcha.
For the cardiac testing, we've got exercise EKG. So we'll hook you up to an EKG.
Oh, you're going to do EKG as well?
Oh yeah, EKG. Not just a resting EKG. Well, for some patients there'll be a resting EKG, but I'm going to have the capacity for my executive program. We'll be doing exercise EKGs.
So on a treadmill or something
on a treadmill.
Like that? Okay.
So that's going to look at your cardiac function. It's a marker of cardiac function. We're not going to be doing exercise echoes here. That requires a higher degree of expertise.
Sure.
We will have ultrasound, so I can take a peek at your heart. So that's the cardiac assessment.
Okay.
For the metabolic assessment, we've got a couple of things. We've got VO2 max, which also combines actually metabolic, cardiac, and pulmonary. That's the maximum amount of oxygen you can use at maximum exertion.
Sure.
It basically
it's not a fun test.
It's not a fun test.
Yeah.
It's not for everybody. Not everybody. If you haven't been exercising and you're coming to us,
If you're at high risk, you can't do it.
you can't do it right away. We gotta build you up before we can even do a test like that.
Yeah, makes sense.
But it's basically testing your maximum aerobic capacity.
Got it.
And then also in that VO2 max testing, the graded exercise testing, we can also calculate your aerobic efficiency, which is a whole separate thing.
Okay.
We can do resting metabolic testing, so where you breathe in and out of a machine while you're at rest.
Okay.
And it's going to calculate precisely.
Like tidal volume and stuff like that? Or
No. So that's for the pulmonary function test.
That's pulmonary. Okay.
This is actually measuring how much oxygen you're consuming and how much carbon dioxide you're exhaling,
Got it.
like the VO2 max, but
Got
it's
it.
much more sensitive because you're not doing with exercise.
Okay.
And what it's going to do is you basically meditate for 15, 20 minutes while you're doing
Got
this.
it.
And at the end of that, we can tell you what your resting metabolism is.
Okay.
So you've heard of people who say, I can't lose weight. I don't eat, but I don't
Right.
lose weight because my metabolism is low. Well, we're going to test specifically your metabolism to see, is it actually low?
Right.
And this is actually a funny thing. If you try to starve yourself, like let's say you're a big dude or gal, and you need to lose weight, and you think, okay, I'm just going to starve myself.
Right. You lose weight initially, and then you scream metabolism up later.
Exactly. So that's exactly what can happen. That's actually a thing. When you can actually mess up your metabolism by trying to diet your way into weight loss.
Can't tell you how many clients I've seen that I would tell them to stay at their calorie count, don't drop. You know, change the type of foods you're eating, because that really is the blueprint as to what your genetics or your hormones are going to do. But don't lower the calories. You don't want to go below your BMR. And they do it. They listen to me. And after a month, they're like, I had lost the thing. Like, give it time. 5 weeks, 6 weeks, right at that 6 week mark, it's like, bam. It's like a time bomb. If they do the opposite, they lose the first 5 weeks. Like crazy. And they get all excited. And then all of a sudden,
it stops.
Bam. And it's like months before they can get it back.
They basically are putting themselves into a starvation state. And the body lowers its metabolic rate because it doesn't know, you know, it might be months before you get food again. I mean, that's how we were living thousands of years ago, is feast to famine. But we're going to measure that.
So you have a test for that.
I have a test for that. We have a body composition analyzer, which is going to test the three things I'm going to get from that is muscle mass, subcutaneous fat, and visceral fat.
Which we've talked about on here before a little bit, subcutaneous and visceral fat, but really the visceral is the dangerous, really, really bad fat under the muscle, around the organs. Stress, alcohol, all that leads to visceral fat, some genetics, right? It's
a marker of metabolic. If you're metabolically unhealthy and if you're messing up your diet, then you're going to get more and more visceral fat. That's what's one of the things that's leading to the epidemic of diabetes and heart disease and cancer and all this stuff that everybody's getting in this country.
So all that you mentioned, what is that, like a 3-4 hour test, something like that?
So to get all the testing, I'm booking patients for 2.5 hours because on top of that we have to do a functional assessment, how you move. For patients that are relatively mobile, I think my bro science, I can handle that, but I'm also going to have a therapist on staff, and I know we've talked about you being available for people to do functional assessments, movement assessments.
Functional movement screening and all that. So we hadn't talked about the price yet. All that, like, it seems really expensive. What is it, like $2-3 grand probably?
Yeah, so I'm going to back up just a little bit. Like I said, I'm at a point in my life where I could theoretically, I don't live expensively. Like, my hobbies are jiu-jitsu, rock climbing, martial arts. It's like, I don't live expensively. Like, I could actually retire. So I don't want to make a lot of money. But at the same time, when I'm thinking about, 2.5-3 hours, when you're adding all these things up, it's like, it's got to be a lot of money. So I'm settling
probably 50 grand worth of equipment right there alone, 50 to 100 grand.
Yeah, it's at least that. I mean, just the VO2 max machine was 50.
So you got to charge a lot.
So anyway, my plan is for the whole package to get all the testing with labs. I'm putting aside an hour of my time to counsel you on everything because there's a lot of data we're going through, and also on top of that, an athletic trainer. If it's just a one-time evaluation, one and done, $1,200.
$1,200?
$1,200. I know I might be undercharging.
I think you are. I could have sworn you were going to say 3, 4, or 5 grand.
I know, but I mean, we live in Lynchburg.
Sign me up now.
We live in Lynchburg. My brother just got this same testing done, and the clinician in St. Pete charged $4 grand.
Okay, so that's what I was thinking.
I mean,
and that's in Florida.
I'm going to have limited patients, and I'm trying to. I don't want this to be just for executives. So I have a PA who's going to be available as well, who probably won't be doing all the testing included, but can still do an evaluation and get you what you need done for a much cheaper price point. And then we can split it up over the course of the year. So if it's just a one and done, that's what it's going to be. But ideally, I'd like to build a relationship with people and monitor them over time. So we can break that up over the course of the year, where you pay basically monthly. And then for an additional subscription fee, $120 to $150. Probably $120 for my PA, $150 for me.
Non-insurance based.
Non-insurance based. It's the direct primary care.
Got it.
We can get into insurance, but that's a whole separate thing.
You don't even want to get me started on insurance. That's a whole different podcast.
I can't take it anymore. I can't take it anymore.
It's the biggest scam of our lifetime.
It really is. And we could do a whole podcast on insurance, but I just can't take insurance anymore. They've corrupted. I don't want to be mean. I know they're just people, and they're probably doing the best they can.
I'm not saying it's
people.
Money. I'm not saying anyone that has insurance companies, whatever it may be, but it is
it's very corrupting.
We filed a claim just for our business, right? And this isn't health insurance, but it's still insurance. And this is the type of scam it is. We haven't had one claim in the last 10 years in our business. We filed one claim for something that went on a surge. It was a power surge outage. Took away one of our pumps. We filed a claim. They said, we don't want you as a client anymore.
Yeah.
$4,000.
Yeah.
We've been paying for 10 years. And it's the same on medical side.
It's the same on medical.
It's fighting tooth and nail to get them to pay for anything.
It's an exercise in how much time can they waste for both the patient and the
and
doctor.
profits keep going up
So people will,
in the companies.
So people won't pay. And the thing that's really gotten me to the point where I was just like, I can't do this anymore. Since I graduated residency, it makes me even, I feel like the visceral fat sort of percolating now just talking about this, because it makes me almost nauseated thinking about this. Since I've graduated and been working as a hospitalist, working in these nursing homes, whatnot, I regularly get education, right? Like every 3 months I sit through a lecture. 90% of the education I've received.
It's on insurance.
It's on insurance, it's on billing.
And how to bill.
How to bill, how to document, how to use the precise words and the precise order that you need to hack the system so that you can get things through, so that you can get paid.
Who do you think has a bigger lobbying group in DC? The insurance companies or the pharmaceutical?
I think they're equal, aren't they?
I don't know. I'd like to know.
It's certainly not the patients, and the doctors have a lobby as well, but it's not as big as either of those. Yeah. And the patients, I don't think, have any lobby whatsoever.
Yeah.
So the fact that I spent now that I'm leaving this, I went to go do an ultrasound course so I can learn how to ultrasound. I want to be able to ultrasound people's livers to look if they have fatty liver, look at their aorta, see if they have big aortas, look at the heart, make sure it's pumping properly, look at the carotids. I'm ultrasounding all this stuff, and it was so refreshing to take a course on something that actually mattered medically.
Yeah.
And I wasn't doing it to bill them.
Sure.
I'm not billing. I don't know. I can't deal with insurance anymore. I'm sorry. I'm sorry if you have insurance and you really want to use your insurance, but I just can't deal with it anymore.
You're not upsetting me.
And the direct primary care, I'm not a leader at direct primary care. People have been doing direct primary care for 5 to 10 years now, and it's working fabulously
it's working
well. I have a direct primary care doctor myself. Even I've been off and on insurance myself. And even when I'm on insurance, I still keep my direct primary care doctor just because it's so much better. And people always worry about, what happens if I get really sick, if, something catastrophic happens. 2 answers for that. 1, there's cost share plans.
Sure.
So I have a cost share plan. And 2, even if you have insurance, most people, I can't remember, it's 75% of people who go bankrupt in this company from medical expenses have insurance. So if you're thinking your insurance is going to protect you,
that's interesting.
From going back, well, yeah,
I have heard that, but I didn't know that they had the insurance.
Oh yeah. Well, just look at if you look at your insurance, it says, okay, your deductible's this much. First of all, you pay $1,000 a month,
right?
And then you've got a $5,000 deductible,
or 10, or whatever.
And then after all that, then you're still on the hook for 20%.
Right.
And by the way,
it's a great deal. It's a great deal, though.
That 20%, if you've got a $200,000 bill, is theoretically $40,000 is you,
right.
and $160,000 is your insurance company.
But they're going to take their part down.
Exactly, but
they
won't actually show you. They'll show you, okay, this is what's left over, 200,000. We got 160. The other 40 is yours. And then now you can't even negotiate with the hospital anymore to lower your 40 because the insurance company already negotiated for you.
Right.
That when you sign that the insurance company
I'll put that in quotes for us.
Right.
Yeah.
You can't even negotiate with the hospital anymore. You're on the hook for that 40. The insurance company behind the scenes has actually negotiated their 160 down. They probably only pay 40 or 50. So it's 50-50. It's not even 80-20.
Exactly.
But you don't even see that part. So, and you can't even negotiate with them because you gave up your negotiating power when you gave it to the insurance company.
Exactly.
Sometimes people with insurance,
it's harder to negotiate, and you don't have as much.
It's very difficult to
leverage.
negotiate, and you'll end up actually paying more if you use insurance than if you hadn't used insurance to begin with.
I believe that.
Because if you don't use insurance, then you're negotiating for yourself.
Sure.
Or your cost share plan is negotiating for you.
Let me tell you this, and you know about my wife last year, right? In the ICU, 60-something days, and we had a almost $1 million bill, right? We had Christian Health Share, which, I can say there's part of it I like, part I don't, but there was a cap that I didn't see on there, $125,000. I didn't see the cap. It should have been $1 million. But we weren't the plus members, which I had no idea we weren't. So we owed $800,000 on top of that cap. We didn't have insurance for that. So I'm like, we're screwed. I don't know what to do on this. We ended up negotiating that bill all the way down to just pennies on the dollar, basically, because we didn't have the insurance. And so people say, "Oh, catastrophic! What happens?" You talk to the hospital directly. You actually pay them more probably than what the insurance company is going to pay them, and you negotiate yourself. And
you can negotiate yourself.
And then they have a payment plan that you're paying less per month than you would for insurance anyway. So you have no deductible to pay for, less monthly, and you have a 10-year plan, and the likelihood of having another catastrophic injury of some sort is very unlikely. So you pay that for 8 years, 10 years, and you're still coming out ahead rather than paying insurance. It's the wildest thing.
If you had insurance, that situation would have been worse for you. I guarantee
100%.
you. They would have come after.
I agree. I didn't think of it as a time.
The
It was
hospital
stressful,
would have
but-
said, we can't negotiate this any lower
Sure.
because they made a deal with the insurance company.
Sure.
And to make another deal with you goes against the deal that they made with the insurance company.
Right.
So they would say sorry, and then all of a sudden they would start looking for ways they can get money,
Sure.
and they'll make you go back.
So the moral of the story is to stay as healthy as possible. Do your steps, eat your greens, eat mega protein, work out consistently, and have fun doing it. Add the sports in, rock climbing, jiu-jitsu, whatever it may be.
Yeah, like the how-to is a whole separate discussion, but I would say that.
And then you do all that right, and like yourself, you don't have to deal with all this.
The wife is a great example. You brought her up. That disease that she had, I'm gonna tell you, like a lot of people in the hospital were thinking that she wasn't gonna make it.
Really?
Yeah, because we know how bad that disease is. We were all worried from the get-go that
They really...
that
Wow.
that we thought it made us bet money. Nobody would take money that she was ultimately going to survive that.
That's the first
The
time I've heard
reason that she did, in my opinion, is because she's working out with you all the time, and she's strong as an ox. And so that's what you really want. You don't want to be going into because most people who have that, they don't survive because they haven't been taking care of themselves, because they aren't strong as an ox, because they don't have good functional status.
Yeah.
Right? They're already more unhealthy than they realize. Now become healthy after you get something like that. It's impossible. If you start healthy,
Man, that was...
and
I
then
don't
you
know
get
why
hit.
that was tough to hear.
Yeah.
Because I hadn't heard that before.
We got a guy on the inside.
They said 8%, less than 8% go on the ventilator, right? She ended up going on the ventilator. So you're talking about the ones that go on a ventilator and have those kind of extreme issues.
How she decompensated so quickly, how she came in. My brother saw her actually.
Yeah.
And like how
He was
quickly she
aggressive.
went from where she was to on a breathing machine. She had a particularly aggressive form.
And that's why they said that.
That's
Because-
why we were like, when we saw how quickly it was progressing, it's like the COVID where somebody comes in and they're, sick as a dog on day 2, and we're like, uh-oh, because like this hasn't even peaked yet.
I'm glad I didn't know that.
Yeah, well, we're not going to tell you, right? But
Year and a half later.
But it tells you like, look at her now.
Wow.
Look
Yeah.
at her now.
She's 90%.
The only way she survives that is because she's been doing all the exercise.
Sure.
I mean, that in medicine saved her life too, but it's the combination.
Right.
See, the thing that we deal with in medicine is we deal with people who are getting these diseases, and then we're tasked with fixing them, but we're fixing them in people who haven't been working on themselves, and that's like 90% of my hospitalist work.
Right.
And it's kind of a revolving door of the same patients that you see for a couple years until they pass away, and then you get the next.
Sure,
And
sure.
then it's just
And I will tell you, based on the experience I had, it opened my eyes to the beauty of healthcare and the healthcare workers. And it also opened my eyes to how chaotic and disorderly certain things are.
Yeah.
And I'll go into saying, like, there were so many things. I'm so glad we had friends that were nurses that stayed with her consistently, because there could have been some really bad things happening to her that we caught. We caught. And then there was other things that I had friends and doctors that worked there, your brother, I mean, just basically angels that helped us during the situation. And the nurses there's a lot of nurses that were incredible, doctors that were incredible. So it was just wonderful to see, but it also shows the disorder that, between nurses and doctors. I mean, there's things that doctors would say, okay, we're going to take you off the gabapentin, or take you down drastically this. The nurse didn't know an hour later, and come in and try to, give, and we're like, no. And then Amanda got released, and there was no orders on how do you take care of the trach opening? How do you, where do you go from here? We weren't contacted again at all.
Yeah.
No neurologist, no one contacted her, said, hey, here's what to expect. It's just like, okay, get out of here.
Yeah.
You're done. And part of that's insurance.
Yeah.
So,
Well, I think a bigger part of that is when you're learning, when you're going through medical school and they teach you how to take care of a patient, it takes you, an hour to an hour and a half to do it the way you're supposed to do it.
an hour.
Minimum. Which, if that's the model I'm using, and I mean, hospital patients aren't any more complicated.
Sure.
Like, really, we should be spending about an hour with each of the patients. That would be about 8 patients a day.
Right.
You know how many patients we round on in a day? 16 is a slow day. Sometimes we go up to 20, 24 patients.
It's crazy.
Because the hospital is at capacity. We don't have enough healthcare workers.
Right.
So
Yeah, it's not their fault.
It-
It's the whole,
the system is collapsing.
system is collapsing.
The system is collapsing a little bit, but it's collapsing slowly, and basically people are getting burnt out and people are getting overworked. And
Well, the
people
same thing,
don't
why
have
you
enough time.
choose your nursing homes for your parents, grandparents properly, like Ruck and Pratt, great example. They have a lot of hands-on, they do incredible work, they're awesome, right? And then you have other nursing homes that,
I'm going to plug in Heritage Green. They're better than Welcome Pratt.
and Heritage Green. Heritage Green. I'd say they're both very, very like top tier, right? So, and then you have some, same as the hospitals, you have the nonprofit, for-profit hospitals, and
They're
you have
all
that-
overworked,
every
though.
industry, but they're all overworked.
They're all
and so
overworked.
you have to be there with your loved ones, and I found that out firsthand.
Yeah.
Unfortunately.
There's definitely science and data that shows that people who have people with them, family with them, have better outcomes than people that don't. And it's not.
I'd see that wholeheartedly. I could say that.
It's all hands on deck.
Yeah.
It's all hands on deck. A lot of people think we can just give it to the healthcare system and they'll prescribe the pill and they'll fix it. We need some help.
Yeah.
Not only do we need help you taking care of yourself, we can use some help with you being a little bit responsible.
Taking
for
notes.
Taking
What the nurse
notes
says,
and
what the
like
doctor
being,
says.
we're all layered. It's the Swiss cheese model.
My sister
right?
caught a descended bladder. That would
There you
have,
go.
she had 1,200
It's a Swiss
cc's.
cheese. Have you heard the Swiss cheese model?
No, explain that.
So so imagine you slice Swiss cheese and the Swiss cheese has holes in it, right?
Right.
For an error to happen, it has to go through all the slices of Swiss cheese. So like the holes have to all line up.
Sure.
Right? And then an error gets through. Every person is a layer of Swiss cheese.
Right.
Everybody has holes.
So it's
but if you
easier
add
the
up,
less layers, right.
if you have lots of slices of Swiss cheese and you rotate them all different ways, it's going to be very difficult to find a channel to go through from one side to the other. So basically, what you are is another layer of Swiss cheese.
Gotcha. That makes sense.
Yeah.
I haven't heard that
So,
before.
so we're all just layers. The doctor is a layer of Swiss cheese. The nurse is a layer of Swiss cheese. The med tech is a layer of Swiss cheese. The HUC is a layer of Swiss
Respiratory
cheese.
therapist and
The respiratory, they're all layers of
physical,
Swiss cheese. And then when you have a family member who's also a layer of Swiss cheese,
Right.
and then you've got a nurse friend who's a layer of Swiss cheese, the rate of medical errors goes down, 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 down,
Gotcha.
down because the errors can go through, maybe it got through 4 people, but then the 5th
Sure.
person catches it. Or maybe the error goes through 8 people, but the 9th person catches it.
That makes
If you
sense.
only have 2 or 3 people, then,
Easier to go through.
then now all of a sudden a medical error gets through. And unfortunately, iatrogenic injuries.
So if you
It's a
had
thing.
to wrap up, because we went way over, but that's okay.
Sorry.
I feel like I need to have you on again. But to wrap up, what would be the number one thing that you would suggest if you had to do anything, workout wise, whatever's on your mind, for the listener? What do you think would be the number one thing for longevity?
That's a hard question because everybody's coming from different places. I'm going to say the number one thing is, let's say community. And what I mean by community,
Okay. I wasn't expecting that. All right.
get help. Because I don't know where you are. Maybe you're super healthy. If you have community, then you have resources to find out what it is or how it is that you need to do what it is you're supposed to be doing.
Sure.
So if you're not in very good shape at all, go find somebody who can teach you where you are and what the next steps are, whether it's an athletic trainer or it's a physician
Sure.
or it's your next door neighbor who's into fitness.
Well, it's not only the expertise, but it's also, like the old saying, you hang around 10 millionaires, you're going to be the 11th, right? You hang around
Right.
10 fit people, you're going to be the 11th.
Community is super important. Community goes back to
Sure.
Amanda had community, right? Community is super important. Community is one of the most important things to prevent dementia, is community and social engagement. So surround yourself with the right people, seek the right help.
Which is why we have here at the tennis courts pickleball and all the swimming and all that we have. I mean, we had a 94-year-old out here playing tennis, fell, skinned up his arm and hurt his wrist and was back at it a month later. 94-year-old.
That's awesome. Super awesome.
Cognitively, he's all there. Physically, same with guys that work out. I mean, it's But it's community, right?
It's community.
Like so
He's got people around him to help him, and so
Yeah. I
The,
like
the
that.
people
Good
who are
answer.
94 who are living at home, who, they're stuck at home and people come check on them,
Mm-hmm.
a couple times a week. Those are the ones that we see in the hospital that, they can't be home anymore all of a sudden.
Sure.
Now we have to find a nursing home for them.
Well, hey, thanks for being
Yep,
here. Man.
thanks for having
Appreciate
me.
it. We'll do it again and a lot more to discuss.
All right, sounds good,
Yeah.
man.